optic atrophy, which is caused by a disease of the intraretina and its blood supply. The causes can be central retinal artery occlusion, status post PRP or RP, retinitis pigmentosa, retinochoroiditis or myopia. And of course, there is the famous glaucomatous optic atrophy, where you can find deep and wide cupping of the pale optic disc and disappearance of the nerve fiber layer. Very important is to divide the optic atrophies into the tempo of the presenting illness. And I'm going to give you some more examples, like laterality, like age. And let's start with the tempo of the presenting illness, where we have the acute onset, hours or days, in cases of optic neuritis, NAION or AAION, AAION being arteritic anterior ischemic optic neuropathy, traumatic optic neuropathy, and then you have the insidious onset in cases of toxic metabolic, nutritional, hereditary optic neuropathies. And in between, we can find the subacute onset in compressive optic neuropathies, inflammatory and demyelinative neuropathies. Laterality means you can have unilateral optic atrophy or bilateral. Unilateral generally goes with optic neuritis, NAION, compressive causes, traumatic causes for optic atrophy. And in bilateral cases, I would put atypical optic neuritis or neuritis, AION, glaucoma, which is a bilateral disease, toxic nutritional and hereditary optic neuropathy. And we have the age. Accordingly, we'll see that children most probably will be with hereditary optic neuropathies or nutritional deficiencies, optic nerve glioma. Adolescents will show Leber's hereditary optic neuropathy, MS, NMO, neuromyelitis optica. Young adults will show optic atrophy in optic neuritis, traumatic optic neuropathy, meningiomas, and older patients in AION, NAION, central retinal artery occlusions, hypertensive retinopathy, diabetes, paraneoplastic syndromes, and of course gender, where males will show us LHON or Leber's, traumatic and toxic neuropathies, females more common in MS, meningioma, collagen vascular diseases, Sheehan syndrome, and of course, in overall, optic atrophy is more prevalent in African than white people. And we have the smaller diagnostic tips that will help us in working up these cases. We all know that optic neuritis is a self-limited disease, but may recur. Compressive optic neuropathy is progressive, and it doesn't improve. NAION does not improve, while AION can involve the fellow eye. And that's the main reason to treat as early as possible. And of course, toxic optic neuropathy can be partially reversible. Now, we've been talking and discussing hereditary optic atrophies, and I didn't want to miss the opportunity to repeat it. We have the Leber's disease, which is, of course, maternally inherited with point mutations in positions 11778, 14484, and 3460. We have the DOA, or ADOA, as it's called in Europe. You know why they don't use DOA in Europe? Do you know? DOA is the abbreviation of dead on arrival. Oh. So we don't use it in Europe. We have in DOA two genes, OPA1 and OPA3, which encode inner mitochondrial membrane proteins, and three loci, which are currently known for DOA. And of course, we have the Wolfram syndrome, which includes diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, which is a disease inherited as an autosomal recessive trait, all ending in optic atrophy. I cannot finish a very short review of optic atrophy without mentioning this disease. So we're talking about Foster-Kennedy syndrome, which is olfactory groove meningioma, first described by Foster and then Kennedy in olfactory groove meningioma, which is optic atrophy actually, and anosmia with contralateral papilledema. Of course, by the way, this is the olfactory groove meningioma. This is a disease caused by a meningioma, which is, as you can see, coming to a dimension of a grapefruit. And you have also the pseudo-Foster-Kennedy syndrome, where you have also in one side an old optic atrophy due to AION, and then on the other side a new AION episode, and it's called pseudo-Foster-Kennedy. There's a take-home message, by the way, in this short review, and I took it from the classical article of Andy Lee from 2005, and he was referring to a very concise work on isolated optic atrophy, and he started his recommendation by saying that it should be ophthalmoscopically diagnosed according to the color, loss of vessels and nerve fibers, and the clinical exam, while taking the history, you can generally come to the diagnosis in cases of prior optic neuritis, NAION, toxic or nutritional optic neuropathies, and hereditary optic neuropathies, or cases of post-papilledema optic atrophy. But if after the complete neuroophthalmic history and examination, patient is still undiagnosed and has an isolated optic atrophy, you have to proceed to imaging. And of course, we're dealing with an MRI of head and orbit with fat suppression, or CT, wherever it's contraindicated. And by the way, in his review, there were 20% of cases where the isolated